My longest RIP surgery, I'm starting my cases. So it was to encounter a humongous intraocular foreign body. It was like a post-traumatic case, clear lens, retrolental written intraocular foreign body, long, slender, separate end. There is a bulbous end, vitreous hemorrhage, and macular detachment. You can see the bulbous end just behind the lens. And it was quite snugly engaged inside the scadal port. So I cleared my vitreous hemorrhage and just extended the scadal port and tried to disengage the foreign body from the scadal side, but that's not coming out. So what next to be done, because I have to remove this such a long foreign body, I took the patient. So I just suddenly remember the film Atari and the technique. It was kind of lasso technique that to catch the animals. So I used a 60 Prolane, 60 Viking suture, made a noose, and just engaged it around the bulbous end of the foreign body, tightened it, and then kind of lasso technique. I'm just giving pressure, and it is coming out from the scadal port, and fortunate enough to remove this such a long foreign body without touching the lens. So lens was absolutely clear. It remained clear at the end of surgery. And a lot of like retinal incarceration was there, band formation and macular detachment. So I freed all the engaged retina from the incarcerated area, deep field exchange, laser. And after 1 month, lens was absolutely clear, retina on, vision was 6/18. But after 4 months, there was silicon-induced cataract and refractory immunosuppression, IOL, and along with silicon retinal. But finally, patient came a few months back, and at the time his vision was 6/9. At that time, it was 6/12, and it was absolutely on. And you can see the macula is quite healthy, and every scar, all the scars is just outside the vision vascular arcade. So it was kind of very like interesting case, and how I removed the foreign body without touching the lens. But that these kind of hurdles you may face to save the lens, and a series of things you try. So this is another another mode of like your longest days you face you may face in your professional life. So now, finally, subretinal PFCL, my longest retinal detachment surgery. So retinal detachment cases are always interesting. Anything, anytime, it is such an, like I should say, it is unpredictable case, or in a predictable, in a predictable detachment cases. So, so this is a case of I thought it was a total retinal detachment, a bit old, but lot of pigmentary changes, and there was few breaks were there, not that much. It's tough. I injected typal blue dye to stain the ERM. I regularly used to do it along with the typal transdermal dye, and then remove the macular ERM as much as possible. To free the macula, it was quite corrugated and impossible injected here, so it was nicely attached. So now I did the all peripheral membrane detection, and there was quite tight, looking very sides quite looking tight. Retina is not absolutely freely mobile. So in those situations, I did with this basic session to remove all the residual vitreous and started doing fluid exchange. Now see what happened. So it was fluid exchange. Now see, there is I can show you once more. So just see, there is migration of subretinal air in the subretinal space. So while doing fluid exchange, so I did a little bit of retinectomy in the infrared area because there are a lot of tautness is there. So taut retina has to be removed, and because sometimes intrinsic retinal contraction can be a problem. So in this situation, so intrinsic retinal contraction was the reason for which there was migration of air inside the subretinal space. So I started doing again fluid exchange, but again the air has gone superiorly, also nasally and superiorly. Now I removed the subretinal. I removed the PFCL, but and did a little bit more retinectomy temporally as well as nasally, and again injecting PFCL to settle the retina, and then planning for more retinectomy in the supratemporal area. But somehow the subretinal PFCL has gone subretinally. So I removed the PFCL also. Again, I injected PFCL over the retina to see one by one, like every complication, it's not going smoothly. So again, I started doing fluid exchange, but still the superior nasal retina was not free and freely mobile, and you can see there is a lot of wrinkling of the retina folds. You can see. So I removed the PFCL again, and again there was migration of PFCL inside the subretinal space. Again, I injected PFCL. And finally, I did retinectomy in the supranasal area also. But still, some amount of traction is there in the supratemporal area. So finally, I did 360-degree relaxing retinectomy. It's kind of 360-degree RR. Now the retina is absolutely free. So it settled nicely. And fluid exchange I completed, and little bit manipulation was required to settle the retina, and laser barrage was done. There was little bit sagging of the retinal fold. I injected PFCL again, and did laser, completed the 360 barrage laser, and finally silicon on PFCL exchange, injecting silicon with the left hand and removing PFCL with the right hand. And at the end of surgery, I injected subsiliconal triamcinolone acetonide, and you can see that after silicon removal also, you can see just after 1 month of surgery, subsiliconal triamcinolone acetonide particle, and finally after silicon removal, patient gained this good vision, 6/60, and it is absolutely flat and attached. Little bit of subretinal PFCL is there, but still it is macula is absolutely free of subretinal PFCL bubble. So this is the situation. Sometimes you may think that that detachment is quite, although it is old, not of basically we are very accustomed with the anterior PVR, but sometimes anterior and posterior PVR, whether subretinal bands are there or not. But there is one condition. This is called intrinsic retinal contraction. This is invisible PR, I should say. It is invisible PVR. So sometimes invisible PVR are really problematic. Which nobody of us, we are. If you are very much aware of the fact that there is 360 intrinsic retinal contraction is there, you are always in the thought that you should do the 360 relaxing retinectomy. But in other situation, you are not intended to do the 360 relaxing retinectomy. Sometimes you have to do in some unusual situation to get rid of other complications. Thank you.
Beautiful presentation. Always fantastic presentations and lot to learn from you. I have a question.
Yes.
Subhendu, do you? What is your thought on heavy silicone oil, or what has been your experience?
Heavy silicone, firstly, it is not easily available. It is costly also. Unnecessary cost burden for our patient. And another thing is, I have injected heavy silicone also, removed it also. But removal is much more difficult than injecting. Heavy silicone, it is not basically silicone, when you are trying to remove it, it will float up. So it will come to your silicone oil, that your tip of the VF But when you are removing heavy silicone oil, it will always drag down. So you have to sometimes you have to use the active suction with the metallic totally removed, and with the high suction, you have to remove it over the disc, from the disc, just like PFCL. It is nothing but mixture of PFCL and the silicon oil that makes the silicon oil heavy. So it is around 22,000 per vial, and it's not so easily available in our Indian market. But still, we used to get it from some other sources, but now we are not using it.
I think 5,000 centi-stroke silicone oil helps a lot.
That will for the long term effect. That will, it's not heavy. It's not a heavy silicone oil.
It's not heavy, but it's a long term in such cases will be helpful because we have done RR and.
Have you kept PFCL post-operatively for a short period in any of your cases? As is,
no.
Okay.
There were, but lots of papers are there in a free graft ARG, autonomous retinal graft for the failed macular surgery. They're keeping the PFCL for like 2-3 weeks. Then again, remove the PFCL and injecting silicone oil. These are the one situation where keeping the PFCL in the post-op period. Another thing, in suprachoroidal hemorrhage, expulsive hemorrhage, also they are keeping the PFCL first 2-stage surgery. They're doing vitrectomy, draining the blood, and keeping the PFCL for 2 to 3 weeks. Then again, doing the PFCL and injecting the silicone. This 2-stage surgery, Dr. Stanislaw Rizzo had did this kind of surgery, 2-stage surgery, keeping the PFCL, what you were telling, in the post-op period. But I have never done it.
I have one question. For relaxing retinotomy, which one is better, in fluid-filled cavity doing relaxing retinotomy or gas-filled cavity?
It's always better to do in the fluid-filled cavity, because you will. What is the reason? Because you have to allow the retina to bleed. Otherwise, you may face the problem if you are not facing it intraoperatively. During the fluid exchange, there is some kind of tamponade, and due to surface tension effect, the blood may not appear. But post-operatively, you will see there is a lot of high fever because patient is maintaining the prone position. But in the case of fluid-filled cavity, if you are allowing the blood to come out so that you can do the cautery and you can stop the bleeding intraoperatively. Otherwise, during fluid exchange, due to pressure or due to surface tension effect of the air, the bleeding may not happen, but it may happen under the silicone oil, and that is much more dangerous than that may come out anteriorly in the anterior segment, and even like corneal blood staining can happen. Then everything is gone out of your head. You have to be under the
case. Isn't it easier for you in this case? There is a detached retina, you can say under FG, fluid gas exchange. So if you did that retinotomy in the fluid gas exchange state, then at that time, you don't have to again start fluid and again remove it, again give PFCL. So you have to do it multiple times. If you did that under fluid gas exchange, the detached retina, if you relax that portion of the retina by doing retinotomy, it will be much easier for you in this case.
Now, if you are sure that this small retinotomy is good enough to settle this retina, not much of traction, or there is any time constant, because you are a lot of cases you have to do, so you are a little bit in a hurry situation. In those situations you can do it, but still, if you are doing it nicely and completely, and in a cool, calmer way, but in a relaxed way, start the infusion, and then judge your mobility of the retina, how much mobile it is. More mobile means more chance of smooth settlement. If it is less mobile, that means some kind of intrinsic retinal attraction is there, so the retina may not settle. So you have to judge your retinal mobility, how much mobile it is.
Another thing is doing long retinotomy, large retinotomy. After that, we usually put a bit of triamcinolone. If the triamcinolone in subretinal space, that time, should we use subretinal?
There is no need to remove it. There's a lot of study has been done, animal study and as well as human study. They are telling that is have toxic effect of the photoreceptor, but in the long run, that doesn't have any effect on the molar cells or the photoreceptor.
Okay. Thank you.